Good morning and welcome to our September Provider Forum. My name is Chauncey Dameron, Provider Relations and Engagement Manager. Next slide. We're going a little bit of housekeeping information. Please make sure that you are able to engage with our subject matter experts and ask your questions in our Q&A chat bubble to the bottom of the screen. And then we will ask, and during our Q&A section, we will unmute you and you'll be able to ask your question live if you have to. Any questions that require any more research, we'll take that back and then we'll provide that on our Q&A or frequently asked questions document that we put on our website. We have the accessibility features and the closed caption to the bottom as well. And then the use of artificial intelligence featuring, including but not limited to, programs or apps to assist with transcription or recording during any Trillium WebEx is not permitted. This meeting includes the following features: recording and transcript highlights. Again, at the bottom of your right-hand corner, you should see a Q&A chat bubble. Click that Q&A icon and you'll be able to ask your question. And then we'll have someone answer your question during the presentation, or if we need to go to your question at the end of the presentation, we will address those in the chat as well as those that are live. Next slide. Now I'm going to go over the September forum agenda. I'm going to do the welcome, of course, in the beginning, and then we're going to go into 1915I updates, PCP provider request for care manager name or assistance process, utilization management, treatment authorization request, the upcoming trainings, claims, housing, network development. CCH will present to us, and then we'll give you some information on provider forum upcoming meetings, and then we'll go over resources, questions, and answers. Next slide. I'm going to give you a little bit of information about Trillium Health Resources. We are a managed care, tailored plan and managed care organization that manages serious mental health, substance use, traumatic brain injury, and intellectual developmental disability services in North Carolina. For individuals receiving Medicaid through the tailored plan, we cover physical health care and pharmacy services as well. We also help uninsured individuals through state-funded services. This is our regional information. We cover 46 counties with a land mass of 28,977 square miles. The percentage of that land mass in North Carolina makes up about 59.61%. Total population is 3,152,058, and the percentage of North Carolina population is about 30%. Our network is based upon physical health providers, which is 54,105. We have about 14,103 behavioral health providers, 452 vision providers, 2,788 pharmacy and medical providers, and we cover all 100 counties. And now I'm going to review our tailored plan partnerships. Our tailored plan partners consist of Carolina Complete Health, which is Trillium's standard plan partner, and they're responsible for our physical health network, including primary care, specialty care, durable medical equipment, vision, long-term services and supports, non-emergency medical transportation, and non-emergency ambulance transportation. Centene Vision Services is our Trillium Vision partner, which is formally involved through our agreement with CCH, and they're responsible for our optometry network. PerformRx is Trillium's pharmacy benefit manager partner and responsible for our pharmacy network. Motive Care is Trillium's NEMT partner, and through our agreement with CCH, they're responsible for our NEMT network. And last, we have the North Carolina Department of Health and Human Services, and they're our oversight entity, and they're responsible for managing the delivery of health and human services in North Carolina for all of North Carolinians. We're now going to hear from Katina Dow Scott for 1915 I Home and Community Based Services.
Morning. You can go to the next slide, please. What are 1959 services? 1959 services are behavioral health services for members who receive Medicaid and want support to live in their home communities. These services are used to support members with IDD, SED, SMI, SPMI, SUD, and TBI. Members can receive these services while they are on the Registry of Unmet Needs list for innovations. They are provided to members, residents, community, and are not for members living in an institution. A provider cannot provide TCM and 1959 service to the same member. Individuals who are enrolled in CAP C, sorry, reverted that, or CAP DA can receive 1959 services, but not respite or community transition services. Next slide. Eligibility for 1959 services, you must be eligible NC Health, Medicaid health plan. Medicaid members on the wait list for innovation services may be eligible to receive 1959 services while they wait. Members do not have to meet an institutional level of care to be eligible for 1959 services. If you're not eligible, it's because you are in a standard plan, innovations, or TBI waiver members. The chart here shows the different 1959 services vary by benefit. Benefit is determined after the 1959 assessment is approved. The chart shows the service, ages, and populations. Next slide. Our first 1959 service is supportive employment for IDD or TBI. A prior authorization is required. This service helps members with severe mental illness find employment and ongoing services with a focus on employment. Service include counseling to understand how work may affect a member's benefits, ongoing treatment to help manage medication, symptoms, and other behavioral health needs. And employment specialists and peer support help members to succeed on the job and advance professionally. Some of the restrictions here. We have a full list that can be linked on this page as well. We just wanted to highlight a few today. Members must have gone through services by employment and independence for people with disabilities before they can get supportive employment. 1959 service supported services employment and CLS may not exceed a combined limit of 40 hours per week, and supportive employment may not be provided by family members who live in the same household as the member. Next slide. 1959 services individual placement and support for mental health and substance use, what we call IPS. Prior authorization is not required for this service. This service helps members find, get, and keep a job that is right for them. A specialist will help them with career planning, discovery, resume, help them with job interviews. They will also help the member with learning their assigned job task and how to get to work. The restrictions here, like I said, we have the link at the bottom where you can look at the full list, but a few we want to highlight is individuals with a sole IDD or TBI diagnosis would not qualify for IPS SE, supportive employment. Must have gone through services by employment and independence for people with disabilities before you can get individual placement and support. 1959 supportive employment and CLS may not exceed a combined limit of 40 hours per week. And even though this service is a NPA, all documentation is still required for the services to include NICE assessment, CMCA, and care plan. Next slide. Okay. Our next service is individual and transitional support, ITS. Prior authorization is not required. This service helps members get support for their recovery from mental health issues or substance use disorders. Members participate and guide their recovery process, have access to transportation, receive help finding housing, manage their finances, and continue their education. Again, the link is here for all the restrictions that apply. But here are a few we wanted to highlight. Cannot be provided during the same authorization period as ACT, CST, Intensive In-Home, MST, PSR, or those ages 16 to 21 who reside in a Medicaid-funded group residential treatment facility or any other duplicative service. Family members or LRP are not eligible to provide this service, cannot be provided during the same time as another direct support service that's covered by Medicaid. Even though the service is under MPA, all the documentation is still required for the service to be implemented, which of course is your 1959 assessment, CMCA, and care plan. Next slide. Our next service here is respite. Prior authorization is required. This service gives caregivers a break while knowing that their loved ones is cared for. Overnight, weekends, and emergency care for the members can be provided in or out the home. There are restrictions, of course, listed in the link, but here are a few to highlight. Respite must not be provided by any person or a legal guardian if they live in the same home as the member. No more than 1,200 units, 300 hours can be provided in a planned year. Respite may not be used for members who are living alone or with a roommate. Members enrolled in CAP C or CAP DA waiver are not eligible for respite services under 1959. Next slide. Our next service is community living and supports. Prior authorization is required. This service helps members learn skills to help them live independently at home and participate in the community. They learn to manage eating, bathing, dressing, personal care, hygiene, and other daily activities, in addition to life skills such as shopping, banking, and extra support for health and safety. A few restrictions: relatives who live in the same home as the member who is under 18 years old may not provide CLS. Members who are in school eligible for up to 15 hours per week when school is in session and up to 28 hours per week when school is not in session. 1959 CLS and SE supportive employment may not exceed a combined hours of 40 hours a week. All right, our next slide. Okay, our last service is community transition. Prior authorization is required. This service helps members get up to 5,000 credit to help them move from an institution or approved setting to their own home. Approved settings may be state-operated health care facilities, a foster or group home, a psychiatric residential treatment facility, a community intermediate care facility, and more. Funding can be used for security deposits for an apartment or house, essential home furnishings like furniture, kitchen utensils, and linens, moving expenses, and setup fees for utilities like phone, internet, gas. Some of the restrictions here is available up to 3 months in advance of the members move to an integrated living arrangement and up to 90 consecutive days post move-in date. Has a limit of 5,000 per individual during a 5-year period, may not be provided by family members, may not be provided to members enrolled in CAP C or CAP D waiver. Next slide. All right, so this slide is showing us the process of assessing 1959 services. The first step, of course, is identification. Member may be identified to need 1959 services. Then a 1959 assessment is performed. CM will complete the 1959 assessment and submit it to Caroline. Determine eligibility. Caroline will review and provide an approval or denial for 1959 services. Then there's development of the care plan ISP. Upon approval of the 1959 eligibility, the CM will work to develop the care plan ISP. This is required 60 days from the TCM consent. Prior authorization, service delivery. CM submits care plan ISP for review. Once authorized, providers will begin to work together to deliver services. Next slide. All right, what are the 1959 service billing codes? Providers should not bill 1959 services until a member has been deemed eligible and authorized for 1959 services. When submitting 1959 service claims, ensure you are using the correct codes and site locations for services. On the chart, please see the codes that are needed on the chart for 1955 services, and make sure those, of course, are included in your plans. Next slide. Who can you contact at Trillium? Here is a list of point of contacts for you based on the situation for you may need. Trillium also has a link on our website now under for provider. Then you go how do I. We have a form that's been recently added there with revisions based off any kind of questions and things that may be presented. Normally we have a response time within 2 business days. So you can see that. And then who is assigned to Trillium. That may be something on the form that you can find out as well. And it also has like contact information for members. You may have questions about 1959 insurance eligibility. If you're having trouble getting a 1959 assessment completed or care plan completed because you're having problems connecting with either the service provider or the TCM, you can utilize that form. If there's service authorization needed, claims or billing needs, if there's a 1959 service code issue, all of those can be addressed using that form. Next slide. Care Plan ISP, TCM 1959. Providers must work together to ensure the care plan ISPs are completed in a timely manner and are fully completed within the correct information on them to avoid issues. TCM will incorporate the results of the independent assessment into the care plan ISP that is completed within 60 days of the 1959 eligibility determination. Explain options regarding the services available, the duration of each service, and include a plan of coordinating waiver services. CM will complete long-range goals, and 1959 service provider will complete the short-range goals. TCM ensures that members provide a signature on the care plan or ISP to indicate informed consent, including signatures for all members and providers responsible for implementation. Plans must align with the birth month. There should be one care plan ISP for a member for CLS. TCM creates a plan and a provider providing the CLS services are responsible for short range goals. Service order signatures. The care plan does not have a specific signature place for the service orders per the TCM manual. Both of the care manager and the service provider should be signing the care plan. So either signature would meet the order requirement for the if QP or another accepted licensure has signed. Next slide. Here is a list of resources providers may use related to the care plan or ISP development. And next slides, the next 2 slides have past FAQs with responses to those. You can go to the next slide that you guys can review. We just want to keep sharing those because we know we have different participants attending this meeting. All right, and then your next slide is 1959. No, I'm sorry. Sorry. There you go. Sorry. This slide. 1959 provider resources. Here we have resources related to 1959 that you may find helpful in the process. And that is my final slide.
Good morning, everyone. I just wanted to go on camera really quickly to wave and say hi. I am Katie Eads, and I am the Director of the Clinical Support Services here at Trillium. And I'm going to talk really quickly about the PCP provider request for care management name or assignment process. Next slide, please. Okay, so Trillium created a way for providers to connect and learn who the assigned care manager is here at Trillium. And so we wanted a streamlined process for whether you're a primary care / physician office, whether you're a behavioral health provider or a physical health provider. So the first step in all of this is for you to verify in NC Tracks that Trillium is the person's plan. So obviously that's the first step. And then also, look to see if Trillium is the assigned TCM agency, but really making sure that Trillium is the assigned plan is the most important part. Once you have determined that information, you can do a couple of things. One is you can Well, you'll fill out this referral form. I have the link there. But if for some reason you're like, I can't find the link, I don't know where my slide deck is, we also have the link on our website. And you can always contact provider support services and say, hey, I need that link to the form where I can, figure out who the care manager's name is. And so they will, also be able to provide you that link. Next slide, please. So I wanted to talk a little bit about what the process is after you submit the referral. So after you submit the referral, the clinical support team reviews the information and we will provide a response within 3 business days. So what the response looks like will really depend on whether the member is assigned to Trillium Health Resources for TCM or for a provider-based care management entity for TCM. So if a member is assigned to a provider-based care management entity, the clinical support team will respond and we provide the name and contact information for the assigned care management entity. And we also then notify the care management entity of the referral and outreach. And so we will when we do alert the provider-based care management entity, we provide them with the name and contact person and the information that was provided in the referral to say, hey, John Doe from this agency reached out wanting to know who the care manager is assigned, and this member is assigned to you. So they also get your information. Next slide, please. If the member is assigned to Trillium for care management or Tele Care Management Agency, we will check to see if a care manager is assigned. And so if there already is a care manager assigned, the clinical support team will provide the name of the care manager assigned to the member. And then we will also alert the care manager of the referral request and provide that care manager with your name and contact information. So the next option that could happen is you reach out, submit a referral form, and that member is assigned to Trillium, however, does not have assigned care manager or care coordinator. So what we'll do is the clinical support team will submit a referral for care management. For assignment time frame, it usually is about 3 to 5 business days from the date that clinical support team submitted the referral. And so what we'll do is, if the referral is assigned, we will then, once it is assigned, we'll reach back out to the person who sent the referral in and say, hey, the referral is assigned. This is the assigned care manager. If for some reason a care manager is not assigned, the clinical support team we will alert you to say, hey, the referral for care management was declined. It could be due to the fact that, someone has Cap C and that is duplicative if you're just looking for, having care management. There could be, a lot of different reasons for that, but we would then, respond and let you know that reason. Next slide. So some helpful tips and hints that this process we have is really for routine care management requests. If you have a member situation where that person has emergent or urgent needs, and you feel like this care management assignment needs to be expedited, or if you are a hospital or an ED and you have someone that's like they need care management immediately, then the best course of action is, instead of filling out this referral form, really is to contact our member and recipient services line, and they can submit the care management referral for you and request that, depending on the situation, that the referral is expedited. We always recommend that, if you submit a request for care management name or assignment, please inform the member you're doing this. If the member has not yet engaged in care management, the first thing that the agency who's assigned to that member is going to do is they're going to reach out to the member and want to get consent for them to be involved with telecare management. But if they don't know they're calling, someone's calling, then they may not answer the phone. I know I don't always answer phone calls that I get that don't have a number that I don't recognize, and that's the same for everybody else. So you informing the member that you submitted this referral and then they may be getting a phone call from either Trillium or a provider-based agency is really helpful in getting that member engaged in care management. Also, just wanted to say, if you have questions regarding personal care services, we actually do have some website information, and so I put that link there. I also just added in some website and helpful information on tailored care management that comes from DHHS, from Trillium, and also from Trillium. So want to make sure you have those links as well. And I think that is the end of my presentation. We go to the next person. Thank you, everyone.
Morning. I'm Dr. Sheila Lee, UM Manager in the Utilization Management Department. Next slide. The objectives for this UM presentation will be to briefly review when prior authorizations are required, the types of reviews and the review process, how clinical coverage policies guide UM decisions, and where providers can find the benefit plan information on the Trillium's website. Okay, next slide. Prior authorizations ensure services are medically necessary, appropriate, and consistent with the benefit plan guidelines and clinical coverage policies. All services have authorization guidelines that are listed on the benefit plan. So each service will have either prior authorization required, which means a TAR is required, or no prior authorization required, means a TAR is not required. So, for example, the acute psychiatric inpatient services require prior authorization after the initial 72 hours of service. All residential treatment services require prior authorizations, as well as PRTFs. State-funded services require prior authorizations. Even specialized services such as RBBHT now require prior authorization effective October 1st. So check the benefit plans for each service, authorization, submission, and documentation requirements. Prior authorization is a utilization management process that ensures the requested service is clinically appropriate for the member's diagnosis, symptoms, and level of care. It also confirms that the service meets evidence-based criteria covered in the clinical coverage policies and align with the benefit plan guidelines. Prior authorization is required to verify services are clinically appropriate for the member's needs. Okay, next slide. clinicians conduct initial and concurrent reviews. Decisions are made based on medical necessity, the clinical coverage policies, evidence-based guidelines, plan coverage limitations, and clinical documentation quality. Okay, next slide. The review process begins when the provider submits a treatment authorization request, known as a TAR, through Provider Direct, along with the required clinical documentation. Once received, the team conducts a clinical review. This means we carefully evaluate the information based on standard criteria and the clinical coverage policies to determine medical necessity. If the documentation is missing, incomplete, or unclear, the reviewer may send a request for additional information. After the review, the request will result in one of several possible outcomes. Approved means the service meets medical necessity, clinical coverage policy criteria, and the benefit plan guidelines. Unable to process is determined if the service is currently under no prior auth, or if a duplicate request is received, or other reasons as to why the request cannot be reviewed. Exceeds benefit plan admin denial is pretty much due to missing or incomplete documentation or requests that are for backdates. Clinical peer reviews are referred to a BHM physician, which is a third-party consultant for further evaluation for a final decision and determination. Okay, next slide. decisions are guided by Medicaid and state-approved policies. We encourage all providers to familiarize themselves with the clinical coverage policies and service definitions. They are evidence-based. There are also standards which outline the criteria for determining medical necessity, and they are both Medicaid and state compliant. Okay, next slide. Where to find the benefit plans. You will be able to find the benefit plans on the website under the Provider tab. Click on the benefit plan service definitions and this screen will appear. Scroll down to see all the Medicaid benefit plans, the state-funded benefit plans, service definitions, in lieu of services, EPSCT, and other important information. This concludes my presentation. Please reach out to at trilliumnc.org for additional information or questions. Thank you.
Good morning. My name's Stacy Henderson, and I'm the IT Programs Director here at Trillium. And I'm going to walk through accessing Provider Direct, submitting a treatment authorization request, also called a TAR, and reviewing the authorization. I will also review ways that provider agencies can reach out to Trillium IT for technical support. You can navigate to Provider Direct through Trillium's website by going to the For Providers page. There are 2 access points from within the For Providers page. The first is a hyperlink that is available midway down directly on that page. You can see this in the screenshot on the left with the red circle. Next to that screenshot on the right is the other option. If you scroll down a bit further on that same page and click on the Learn More button in the purple box for provider contact information and portal, this will take you to where you can access either the Trillium Provider Portal or the Provider Portal for our fiscal health partner, Carolina Complete Health. In addition, once you are successfully logged into Trillium's Provider Direct portal, you then have access to navigate to Carolina Complete Health's fiscal health portal via a hyperlink. This is displayed in the figure at the bottom of the slide with the orange banner. Next slide, please. Once you are logged into Provider Direct, you will first come to a landing page, also known as your dashboard. From there, if you click on the Clients module at the top of your screen in the green bar, this will allow you to navigate to the Client search screen. There are several search combination criteria allowed to successfully search for a member. If you do not use the correct search combo, the system will gently prompt you with a message relaying all the possible search combinations you can use. Once you have successfully searched the member in which you want to request approval for services, you will land on that member's specific client homepage. From this page, you can look at previous treatment authorization requests you have submitted, or you can go in and start a new client TAR. You will do this by clicking on the TAR tab on the client homepage. Once you are on the TARs page, click on the green button on the left top side of the page that says New Client TAR. Next slide, please. The first step in the TAR process is to complete the initial setup of the request you are making. The client information is at the top of the page, as well as the provider name, and this will be auto-populated. You will need to complete the sections with the radio buttons as well as the provider contact information. Once you have filled out the necessary areas, click on the Save and Continue blue button. Please note that any field that has a red asterisk will have to be completed to successfully save and continue on to the next step of the TAR process. Next slide, please. Once you have successfully completed and saved the setup page of the TAR, you will be prompted to complete the diagnosis information. For the diagnosis code, you can search by the actual ICD-10 code or the diagnosis description. Once you have completed all necessary information on this page, click on Save and Continue. Please note that at any time during this process, after you click on Save and Continue, your TAR has been saved to the system. This means that you can come back in and pick up where you left off if needed. You can access this TAR by going to the member's client homepage and going to the TARs tab as previously shown, or you can see all the TARs you have started but have not submitted to Trillium on your main dashboard page. Next slide. The next step is to add the services that you are wanting to request for this member. This slide offers some notes that may be useful for troubleshooting common issues related to this page. These tips are also provided on the Services tab within Provider Direct. For instance, if you are unable to select the service you want from the Services dropdown, it could be that the end date in the date range section expands beyond the member's insurance eligibility end date. Or if you successfully select the service you want, but you cannot find your provider agency and location in the provider dropdown, that can mean that the particular service is not showing in your contract, or you may not be contracted for that specific location you were looking for. Once you have completed everything needed, click on Save and Continue. Next slide. The next step is entering the treatment history for the member. Once you complete the treatment history, click on Save and Continue. As you see, both of these fields are required in order to move on to the next step as indicated with the red asterisk. Next slide. The medical information will be the next step in the process. A note that is worth mentioning for this page is that the two drop-downs that are mandatory may require additional information depending on the response you supply. If you select no for either of these, you will be required to add notes as to why you selected no. Please note that the text box for the response will not populate until after you have saved and continued. Don't be alarmed by an error message that this page will display. It is simply just prompting you to supply a response. Once you add your response to the text box and hit Save and Continue again, you will successfully be directed to the next step of the TAR process. Next slide. Depending on if you're requesting a substance use service or if you supplied a substance use diagnosis, will determine if the SA History tab displays for you to complete. If there is no indication of substance use history in the previous tabs of the TAR process, this tab will not populate for you. If the tab does show, just please complete and click Save and Continue to move on. Next slide. We're finally on the final step of the TAR process. At this point, you can step back through the previous tabs of the TAR to make sure there is nothing else you need to add or change. If all looks good, you can go ahead and complete the fields on the Review tab. You will need to indicate the treatment type, if it's voluntary or involuntary, or if this is an expedited request. In addition, you will be required to supply a response on the reasoning for why you are requesting the service for the member in the text box at the bottom of the page. Once these areas are complete, click Save and Continue. Once you click Save and Continue, you will see at the top of the screen in the green banner that the TAR has been saved and a TAR number will be provided. See the red circle section on the screenshot on the left. This does not mean that the TAR has been sent to Trillium for review. You will now need to go in and click on the blue button that says Submit TAR to MCO. After you submit to Trillium, the top green banner on that page should now change and indicate the TAR has successfully been submitted. This is displayed in the circled section on the screenshot on the right. Next slide, please. After the TAR has been reviewed by the Trillium Utilization Management team and has been approved, you should then be able to see the authorization. Authorizations can be reviewed by going to the Authorizations tab on the client homepage, where you can see all authorizations for your agency for that particular member. Or you can go to the TAR module from the main menu at the top green bar in Provider Direct, hover over TAR, and select Print Authorizations. This will allow you to see all authorizations for your organization and not just member-specific authorizations. On either of these screens mentioned, you can click on the printer icon to bring up the PDF version of the authorization to save or print for your records. Next slide, please. Provider Direct also includes some great resources and trainings that you can quickly access by going to the training module in the green bar at the top of the screen. If you run into any issues, we recommend quickly viewing these resources. And if you still need any assistance, you can utilize the feedback button displayed at the top right-hand corner of Provider Direct. Additionally, you can contact Trillium's IT department for Provider Direct support by emailing pdsupport@trilliumnc.org. And this concludes my presentation on Provider Direct, and I will hand it over to the next presenter. Thank you.
Good morning. I'm Brooke Mickelson. I'm the Director of Program Coordination here at Trillium, and I'm going to talk to you about some of the upcoming events that we have going on. So our newest addition to the simulations that we provide is the post-disaster simulation, and this walks people through the journey and the barriers that people may face following disaster in the weeks following those disasters. And we had our first successful one in Pender County in July. And so we are trying to roll this out to several other communities before the end of hurricane season this year. So we will be in Brunswick and Onslow both in October. And after the Pender event, UNC Wilmington reached out and is inquiring about maybe having it at their campus in 2026. So there's a couple that you could register for now. And I know in 2026, we will be offering more of these as well. So that's our post-disaster simulation. And then we can move on to the reentry simulations. So our reentry simulations, they walk through the barriers that individuals face when they are being released from incarceration, whether that's jail or prison. They face a lot of major barriers. And so we want to make people aware of what those things are and create that empathy. So we have quite a number of those scheduled. We will be in Edgecombe County in October and then Dare County in November, and that will round out our 2025 calendar. And then moving into 2026, we will be in Lee, Beaufort, and Pasquotank in January. And in February, we'll be in Pamlico. And we are also working currently with Scotland to get their date on the calendar, as well as with Bertie, Northampton, and Lenore for March, April, and May. So be on the lookout for more of those registrations to open up as we get all the details confirmed. And then our last one are the Supporting Children Early simulations. And this walks you through the life of a family that has children with disabilities, particularly young children who are seeking a proper diagnosis so that they can get connected to the proper services. And so this really highlights the barriers that a lot of families face just with daily life. And then also trying to care for a child with disabilities. So we have the next one coming up this month in Guilford County. We'll be at High Point. And then in November, we've worked with Sampson County Schools and Clinton City Schools to be able to offer this one. And this is open to anyone in the community to attend as well. And then we will be in Edgecombe County in December. And we are working on the registration for events in Brunswick and Anson counties for 2026. Next slide. And then this I like to show is just a really good overall map to show all the places that we've been to provide all of these simulations, as well as summits and symposiums. And the pretty little stars show all the places that we've been, and the pins show all the places that we are going. So these are all the things that we have done or we have scheduled out so far. And our goal is to cover the entire map and make sure that we have been to every county. It just takes time and we can only do but so many events a month, but our plan is to be able to get to each of these counties, which each of these types of events over the course of time. So that is the information that I have, and I will be on the lookout for any questions you may have in the Q&A. Thank you so much.
Morning, everyone. My name is Jacqueline Thomas, and I'm a supervisor here in the claims department at Trillium. And I'm going to be talking about claim denials with you today. Next slide, please. So the first one that we're going to look at is code 62, which is service not authorized. So if you do encounter claim denials for this particular code, in order to resolve that, you want to first make sure that you do have a current authorization for the member, for the service, covering your actual data service. If you do notice a discrepancy, you'll need to reach out to our Utilization Management department. We have the email address here for them, um@trilliumnc.org. We do have some additional resources that you can consult on Trillium's main website. We have a very helpful tool there, the Prior Authorization Services tool. You can click on it, input your filters to determine if the service that you need to bill does require an authorization. We also have the link here for our benefit plans and service definitions as well. The next denial code is 330, which is patient not enrolled on the date of service. You will see this denial code if the claims you're billing fall outside of the member's eligibility effective dates. You can check Provider Direct as well as NC Tracks to review your members' eligibility. I do have the link for NC Tracks here. You can also access Provider Direct. There's a very useful training tab in the Provider Direct portal where you can access several trainings, one of them being the client search, insurance, and target pop training that has proven to be very useful for our provider community. Any questions regarding a member's enrollment or their eligibility can be directed to our enrollment and eligibility department, and I have their email address here as well. You can also experience this denial if you're billing a service code that is not included for the member's eligibility type. An example of this could be if you're billing a state-funded service, but the member has Medicaid, and vice versa. Next slide, please. The next denial code 1018, which is a timely filing denial code or claim received after billing period. Claims received after the required time frame will deny as specified in your actual contract. Timely filing guidelines, they can vary between the lines of business and funding sources. In certain appropriate circumstances, you do have the option to request a time limit override if you do encounter a denial for 1018. You would submit a claim request form via the Trillium website. We have the link here for that. There are explicit instructions for submitting the CRF forms and also the inquiries on our website. We do have additional information and resources for you that talk about timely filing. The link for our claims billing guide is here, as well as our prompt payment tip sheet as well. Another denial code 1271, billing provider NPI and billing 9-digit zip. The billing provider NPI and billing 9-digit zip code combination not found in our system. The steps you would need in order to resolve this is to first check NC tracks. Make sure that the MPI and address and NC tracks match to what you actually submitted on your claim. If there is a discrepancy or you notice that the addresses in your contract do not match, you will need to outreach our contracts department, contracts at trilliumnc.org, to have them make updates if necessary. After confirmation of update is received, you can actually rebill the claim. Again, I do have the link for NC Tracks here. Another denial code is 1377. Please submit to Carolina Complete Help for processing. And in essence, this means that the physical health claim has been submitted to the wrong processing system. On Trillium's main website, we do have a wonderful resource for providers called the Tailored Plan and Medicaid Direct Claims Submission Protocol. And this protocol is very instrumental in helping you to determine exactly which portal you need to submit your claims to, whether it's behavioral health or physical health. And next slide, please. The next denial code 1027, invalid service or service discontinued. When you encounter this claim denial code, you'll definitely want to review the service code you're billing. Check to see if it is active in Trillium's benefit plan. I do have the links included below for our benefit plans and service definitions. Information concerning covered procedure codes is also available via the NCDHHS online covered procedure code site for North Carolina Medicaid. That link is also below. The next denial code 1073, client has other covered insurance or COB. As payer of last resort, the member's primary insurance, whether that's Medicare or any other private health insurance, Blue Cross Blue Shield, they must be billed before Medicaid. You may need to check with your members to verify who their third-party insurers are. Also verify the information in Provider Direct. Check to see if the primary insurance is incorrect or somehow missing from our system. You are welcome to submit a ticket to our claim support queue if you do need further assistance with updating the member's insurance. For example, if it's indated or something of that nature. Following all validations and billing to third-party claims can be submitted to Trillium. Please be sure that you do include the COB information on the claim. Again, we have the link for NC Tracks here and also the link for accessing the Provider Direct portal. Next slide, please. Also on our main Trillium website, we have something that is available. When you go to the website, it's under the provider section, provider documents and forms, and it is called our known issues tracker. And this is very helpful to reference if we do have or we identify claims processing issues that are technical in nature and our IT department is working to resolve them. They will be added to the known issues tracker you can view what the issue is, and they do include an estimated time frame for when they expect to fix the issue. So it's a wonderful tool for you to consult to see any known issues that we have going on with claims processing. There again, we talked about this in an earlier slide, our claims submission protocol. The link is here and it's also available via Trillium's main website. Again, it's a wonderful tool with a lot of billing elements. There again, it's very useful in helping you to determine which portal you need to submit your claim to, whether it be to Trillium's behavioral health portal or to the physical claims to the CCH portal. Next slide, please. If you do have any questions regarding any of your claims, claim denials, any questions at all, you can actually reach us by emailing claimssupport@trilliumnc.org. When you send an email to that email address on the claim support email, it's going to generate a case ticket in our claim support queue, which will be routed to one of the members of our claims relations team, and they will be more than happy to help you troubleshoot your claims denials, claims questions that you may have. The provider support services line is always available for you at 855-250-1539. Next slide, please. And I will turn it over to Amy for housing. Thank you all. Have a great day.
Good morning, all. I'm Amy Michael, the head of housing here at Trillium. Next slide, please. So the housing department is completely separate from PCL, any other group homes, any kind of housing that services are attached. We are a standalone department. We administer federal housing grants. That's all we have. That's the only resources we have are federal housing grants. We try to seek new funding to support an increase in affordable housing. We build and maintain relationships with public housing authorities and other organizations that offer affordable housing resources. The hope there is to be able to be notified when waiting lists open up, or have a contact at housing authorities who can help us navigate the application process and keep our members' information updated if it changes. So when their name comes up on the wait list, they have all the correct contact information. We connect with community agencies and organizations to fair housing and request for reasonable accommodations and modifications training. We promote positive relationships with landlords and act as a mediator when needed between landlords and tenants. Our landlords have become extremely important to us over the last 10 years, and we'd like to build good relationships with them for obvious reasons, also to make them feel more like a partner than a resource that we use. We talk to our landlords a lot, do check-ins to see how things are going, if they need anything, or we, have any, if they have any ideas about how we could change things to make it easier on them. And we also participate in continuums of care throughout our catchment area. Next slide. So the continuum of care is a group that coordinates activities to meet the needs of individuals and families who are experiencing homelessness. Our programs only deal with people, only serve people who are experiencing actual homelessness. It's a mechanism for us and other agencies to apply for federal funds. We have to go through this continuum of care to get any of our funds. It promotes community-wide commitment to the goal of ending homelessness by providing funding for efforts by nonprofit providers and state and local governments. And it also promotes access to and effective utilization of mainstream programs by homeless individuals and families. So the continuum of care also helps connect people who are experiencing homelessness to Section 8 vouchers, rural development places that they can rent, anything we can connect them to, not just our programs or other agency programs, but other housing. That the continuum of care helps us do that. Next slide. So the continuum of cares that Trillium is involved with, the majority of our catchment area, 42 counties, fall under the balance of state continuum of care. And that's all the rural counties in North Carolina. So the balance of state is 79 counties in North Carolina, and we're 42 of our counties are in that. Trillium's current housing programs are under the balance of state. The reason for this is Guilford County has their own standalone continuum of care, and so does Brunswick, Pender, and New Hanover. They all have their own standalone continuum of cares, and they have other agencies that administer the same housing that we do, same housing programs. The other two COCs in Trillium's catchment area, just like I said, is Guilford County COC and Cape Fear Homeless Continuum of Care. Next slide. And this is just a map of that balance of state continuum of care, all those rural counties. And currently, Trillium is active in 7, 8, 9, 10, 11, 12, and 13. That's just a visual to show you how big those areas are, as y'all know, I'm sure. Next slide. So our housing programs, all programs in the housing department are federal grants. Like I said before, they come from the Department of Housing and Urban Development. One of Trillium's grants has been in continuous operation for 25 years, and I've been doing housing for 21 years. So that grant is older than my time in housing. I've carried that grant from mental health centers to LMEs to MCOs and now tailored plans. All Trillium housing programs follow the Housing First model and are only accessible through the coordinated entry process. The programs that Trillium administers are permanent supportive housing, formerly shelter plus care for some people that have been around for forever, balance of state, and coordinated entry. So I can't remember if I talk about Housing First later on, so I'm just going to stop here and talk about it now. Housing First, for those that don't know, is exactly what it sounds. It's not a program, it's a model. We follow the Housing First model, meaning if someone is experiencing homelessness, what they need immediately is housing. They don't need treatment, they don't need therapy, they don't need somebody preaching to them about getting sober, they need housing right now. And once they get into housing, then we can begin to have those discussions about services and supports other than housing. Next slide. Not going to read all this to you, I promise, but it's just talking about the criteria for all of our continuum of care programs. People must meet these definitions. So one is a primary nighttime residence that is public or private place not meant for human habitation. Another is living in a publicly or privately operated shelter. And a shelter can also look like somebody like a federal, state, or local agency, charitable organization paying for a hotel or motel. If the person's family, friends, or themselves are paying for that motel, they're not considered homeless. To HUD, they're considered as having resources that they can use. So they either have to be in a shelter or be in a motel paid for by a charitable organization, federal, state, or local government program. Or exiting an institution where they have resided 90 days or less and were homeless prior to entering the institution. They only have to meet one of those three definitions. Can't be staying with family and friends. Can't be, got an eviction notice, but they're still in their place. They have to be on the street, in a shelter, or in an institution 90 days or less and homeless previously. Or any individual or family who meets the DV definition, is fleeing or attempting to flee, has no other residence, and lacks the resources or support networks to obtain other permanent housing. So I know that was a lot, but yeah. Next slide. So our permanent supportive housing program prioritizes chronically homeless individuals and families. That means they have a long-standing disability that significantly impedes their ability to live independently, meaning they need permanent supportive housing with some kind of supports and services. Again, we don't force it on them, but we have housing coordinators that do go in, check on people periodically. Whatever the needs of the household is depends on how often they're checked in on, and encourages them to get into services. They have been unhoused continuously for a year, at least 4 occasions within a 3-year period. When I say we prioritize chronically homeless individuals and families, that just means if we have an open slot for someone, then we go to the wait list. And if there's a person on that wait list that's chronically homeless, we take them. If there's not, then we can take someone who's not chronically homeless. But we have to prioritize if somebody is on the list. Next slide. Who does not meet the definition? Like I said earlier, staying with friends or family, staying in a hotel paid by anyone other than a charitable organization or government agency, or received an eviction notice but still living in the unit. Next slide. Housing First. I thought maybe I had a slide about this. We know Housing First ends homelessness. Again, if you're homeless, you need a house. If you're hungry, you need food. It's the same concept. It's a national best practice model, not a program. It quickly and successfully connects individuals and families to permanent housing. This is not always quick, just because it's hard to find people housing. It's hard to get them, into the system and then get picked off the list because there's not a lot of resources, as y'all know, but it is the quicker way rather than coming up with some kind of arbitrary conditions before we're housing people. No preconditions such as sobriety, treatment compliance, and service and/or income requirement. We house people all the time with zero income. It's hard and we have to figure a lot out, but we do it all the time. We offer supportive services to maximize health stability, to prevent returns to homelessness, rather than meet arbitrary benchmarks to permanent housing entry. Housing First is cost effective. It keeps people out of jail. It keeps them out of our emergency rooms. We have really good health outcomes with our folks in our permanent supportive housing program, so we know it works. We've been administering these programs for that one grant for 25 years, and we've always done the Housing First model. Next slide. So before I forget, our grants at Trillium, these particular grants are not just for Trillium members. Since they're federal grants, they're open to anyone in our communities and our catchment area that meet the definitions of these programs. So just keep that in mind. Our permanent supportive housing program is a voucher program very similar to Section 8. It's also funded by the Department of Housing and Urban Development. Participants must be chronically homeless, have a disability, or low to no income. It provides rent and utility assistance based on income. It's scattered site housing in the unit and community of their choice. So just like getting a Section 8 voucher, they can go out and find a unit. We can inspect it, go look at it. It's the appropriate size for the household size. It meets, safety inspections. Then that can be their home. Services are encouraged but are not required to participate in the program. I know I keep saying that, but I think that's an important aspect of our programs. Housing case management is through the housing department. It's not a clinician going to their house. It's just someone who's a housing case manager. They know how to help people maintain their housing. Technically, it's permanent with no time limit, but we do start having conversations with households upon entry about, what does success look like for you? What does graduating, so to speak, from this program look like for you? We plant that seed and sometimes success is just maintaining their housing in the permanent supportive housing program, and that's okay. But lots of people have called us or talked to their case manager and said, you know, I think I'm ready to go off the program. And we've taken the voucher and they've remained in that house and continued on. These numbers are a little off, but approximately right now we have 175 households, 300 individuals, which is 224 adults and 76 children. I think we forget sometimes that with the adults that we see on the street or hear about, that there are also a lot more times than not children involved. This is available on most of Trillium's catchment, but not administered by Trillium in those counties. Most of those counties, though, have access to permanent supportive housing through other agencies. We just don't have them in those counties right now. Next slide. This is our newest program, Back at Home, Balance of State. This is across all 79 counties in the balance of state. The reason it's only in the balance of state continuum of care is because it's for rural counties. It was a grant specifically designed for rural counties. It combines permanent supportive housing and rapid rehousing. Permanent supportive housing we just talked about. Rapid rehousing is time limited. It can be 6 months to 2 years. Same setup. They don't have to be chronically homeless though. It also adds street outreach, which has been really exciting for our department. We've always been missing that street outreach portion. We've gone to meetings and gotten phone calls with people telling us, you know, so-and-so's sleeping in the doorway of whatever restaurant in Little Washington. And we've literally had no means to be able to physically go out and check on that person. It just wasn't what we did. We didn't get paid for that. And so we would have to wait until that person connected with the right person and we could assess them and do whatever we need to do to get them into housing. Now that street outreach those folks get paid to go out and check on people. Sometimes it takes months for us to get people to trust us enough to start assessing them, start, you know, filling out paperwork. We've had one lady tell us, you know, that she trusted us, but she just wasn't ready to go in yet. So we just keep checking on her once or twice a month or once every other month. But we love that piece. We love being able to get out there where people are really staying and connected with them. It's a 3-year grant. It started in 2023. We got started about March or May of 2024. This part of the grant, this first grant will end in 2026. They're going to apply for the grant again this year, so we'll have it when it ends in 2026. The sub-grantee is now North Carolina Department of Health and Human Services. The NCORE, the North Carolina Office of Resiliency and Recovery, closed and they transferred the grant to DHHS. Like I said, it includes all counties in the balance of state continuum of care, rural specific grant. These numbers have definitely gone up because we've added more counties. Currently in the program are 124 individuals, 246 households, 246 individuals, 148 adults, and 98 children. I think it's more like maybe close to 140 households now. We've taken an agency wanted to get rid of their grant, and we took on 25 more households. So maybe 150, yeah. And the program covers all of those counties and other agencies within the balance of state. For all of the other counties, they cover this. They do the same program for counties that we don't cover. It's available to all 79 counties in the balance of state. Next slide. Coordinated entry. This is the process that connects people to all the resources that I just talked to, plus any other resources in communities that other agencies administer, because Trillium's not the only game in town, as y'all know. Coordinated entry increases the efficiency in homeless services by standardizing how people access programs and coordinating referrals. So back in the day, before coordinated entry, it was who you know and how were you at the right time, right place at the right time. If somebody at DSS knew I had a program, they would call me and say, do you have any openings in your permanent supportive housing program? And I'd say, yeah, let me send you an application. And so that person that they just referred to the program may not have been as need the services as much as someone else that I had no idea that they needed. They're out in the woods living in a tent, even though that person exists. So this person that may not need it as badly is getting referred to the program. This eliminates that. We can't take anybody without going through the coordinated entry process. HUD requires all of us to implement coordinated entry. And then the balance of state continuum of care uses a decentralized coordinated entry system. So each of our regions in Trillium, those 7, 8, 9, 10, 11, 12, 13 that I just showed you, we have a decentralized system. So the North Carolina Balance of State Homeless Assessment and Referral Tool, HART, is the tool we use to assess the vulnerability of families. It assesses the vulnerability of the individual or family if they continue to be unhoused. We are literally assessing how likely people are to die on the street if we don't house them. It's very sobering. But it's exactly what we're doing. We housed many years ago, our department housed a couple, an elderly couple, and they had been homeless for 10 years. Both of them had chronic health conditions, and we got them in a little trailer. They were happy, and the wife was dead in 6 months. So I think it's really important that people view homelessness as the crisis that it is. Guilford County and Cape Fear use a centralized method, which is nice because they still use the VI-SPDAT, but it essentially does the same thing as the HART. And while we don't have programs in Guilford and Cape Fear, we know how to get people connected to their programs. Next slide. Trillium is a coordinated entry lead in the following regions, which means we have 2 staff at Trillium that are grant funded that do nothing but coordinated entry. They make sure people get on the prioritization / waiting list. They keep up with people on the waiting list. They reach out to people who refer people to the program to see if, a person's been housed or their situation has changed anyway. I'm not going to read all those counties, but there they are. They serve as the primary CE system contact for the balance of state staff for each regional committee. They attend monthly council meetings. They facilitate regular case conferencing meetings where the community selects individuals and families experiencing homelessness for permanent housing resources. They maintain the regional committee's by name list in the homeless management information system and provide information to regional partners during case conferencing, such as if there are any openings or there are going to be any changes to the system. They also maintain regular contact with participating agencies to troubleshoot ongoing challenges. Next slide. You can access our housing programs by sending an email to housingservices@trilliumnc.org. Please include name of head of household, current living situation, city and county they are located, and contact information of persons submitting the referral. Someone from the housing department will follow up with you regarding next steps, and this will depend on where the individual family is located. Yeah, it's not, we don't have any emergency housing. We don't always have openings. I mean, we stay pretty full, but please reach out if you have a need. We may be able to connect you with other resources that we're aware of. Yeah. Okay. Next slide. Again, Trillium's housing department is separate from the Transitions to Community Living department. We do not have any emergency funding or housing. We just don't have it. Ours is long-term housing. We don't provide hotel stays, And we only work with independent community-based housing and not group homes, adult care homes, etc. And if you have any questions, just drop them in the Q&A. Thank you.
Thank you, Amy. And thank you, everybody, for joining us today. My name is Richard Duranga. I am a Network Development Unit Manager here at Trillium Health Resources, and I'm going to be sharing our current service needs. So at Trillium, we regularly review our network to ensure that our members have timely access to care. Whenever we identify that that isn't the case, then we post these service needs. And we're going to share them with you today, hopefully, so we can get some eyes on these needs and partner with you all to find a solution and make sure that our members get access to the supports that they are requiring. So some of our current needs are adult partial. Let me back up one. All of these services that I'm about to discuss right now are licensed services. So they would all require licensure. So I just wanted to make that clear. We have adult partial hospitalization in Dare and Hyde counties. We have child and adolescent partial hospitalization in Dare County. We have opioid treatment program in Anson, Beaufort, Bertie, Dare, Hyde, Lee, Richmond, and Washington counties. Psychosocial rehabilitation in Brunswick, Currituck, Dare, Hyde, New Hanover, and Onslow counties. Substance abuse comprehensive outpatient treatment, or SACOT, in Dare and Hyde counties, and substance abuse intensive outpatient in Dare and Hyde counties. If you are a provider that is interested in offering any of these services in any of these counties, you can go onto the Trillium Health Resource website under For Providers and click on our network participation opportunities, and there's a link where you would go ahead and submit your application. So thank you all. Have a good one.
Good morning. My name is Gaines Carey, and I'm the education trainer for Carolina Complete Health Network. Next slide. And next slide. As stated, Carolina Complete is responsible for processing physical health services for members enrolled in the Trillium Tailored Plan. And due to that, we have our own portal. So we have the Trillium Physical Health Secure Portal. In that portal, we have key functions that you can use to check member eligibility, prior authorizations, claim submissions, claims disputes. You can view payments, view health records, and more. So if you're not already signed into this portal, we highly encourage you to get set up. You can use this link here to go ahead and begin that process. If you have any questions pertaining to how the portal works, or if you have any questions getting started in that portal, you can reach out to the Provider Engagement Administrator at this email listed here. As a contractor or contracted provider, you are assigned a Provider Engagement Administrator per organization. So they're happy to work with you. In addition, that middle bullet point is a link to our new provider orientation, which in the appendix has multiple screenshots of how to utilize that portal as far as submitting claims, prior authorizations, and more. Next slide. So just to add on to that, if you are if we use a third-party biller, they also have access to that portal. What you would need to do is when you do that initial setup, you need to assign a portal account manager to your organization. So that portal account manager would then need to invite a user, and that would generate an email to that biller. At that point in time, the biller would then input the tax ID number, phone, and fax number, and then it would generate a response to the account manager to go ahead and verify that account. So just know that that feature is available. Next slide, please. So just wanted to highlight some trend with the claim denials for the last 30 days. I won't go into each of these, but because there's some of them sort of, overlap. But that first one that we're looking at on that top line is that non-eligible, non-reimbursable services per plan or regulatory guidelines. So on that other column, we have provider guidance. So basically, they're saying that the service billed is not covered and non-reimbursable based on the NC Medicaid fee schedule. So I've linked here that fee schedule. So you always want to refer to that. And then also you want to refer to the clinical coverage policy and make sure the procedure is billable for your provider type. So there's a link here to the clinical policies. And then the next three slides are the next three denials are sort of all related. There are bill or provider taxonomy required, deny bill NPI and taxonomy, not on Medicaid file or not active on SVC dates, or the referring provider NPI not in Medicaid file, not active on SVC. So basically for this, the bank guidance is to make sure that your provider data has active credentialing status with NC Tracks and that the data on the claim matches what is in NC Tracks. So as we all know, NC Tracks is our source of truth. So again, just make sure you're current. We do have that additional provider enrollment and data PDF linked here as well. And then that last top denial is denied due to revenue codes not billed on the UB92. Please resubmit. So this denial occurs when the required revenue codes are missing from a claim submitted on that UB92 institutional claim form. So you want to verify that each bill service line includes the correct revenue code that matches the service and corresponding CPT HCPCS codes. I've also linked the billing guide here and the page that you can find that information. Additionally, just as someone stated earlier, we have a known issues tracker as well. And this just is updated weekly on Fridays, and we just input known issues that are impacting providers. So please always check this as a resource. Again, it is updated weekly, and yeah, okay, so that's it. Next slide, please. Additionally, we do have some trainings available. We had a PCS provider training earlier this year. It was recorded. The slides are linked here, and a Q&A was formulated from that. So if you are a PCS provider, please utilize the links here. We do offer a Trillium physical health provider orientation each month, and you can register for that. On that call, you have representatives from our side, CCH, as well as Trillium. Additionally, if you are a new provider and you just want to make sure that you've done everything to get set up, we do have that onboarding checklist PDF here. And if you are a home health provider, big things are changing. We've got that EVV hard launch that's happening in a couple weeks, October 1st. So please, if you are a home health provider, please make sure you are set up HHA Exchange and you've got your EVV solution in place. If you have any questions around any of that information, we do have home health office hours. Our next one is September 18th. And again, it's partnered with Trillium. So we've got both sides of the house there to help you. That is at 11 a.m., like I said, on September 18th. And just use this link to register here. And next slide. And just some additional resources from previous forums. We have the provider and billing manual linked here, as well as some billing guides. We've got some DME information. I've linked the Trillium Taylor Plan Provider Resources page. And if you have any questions at all and you're not sure who to connect with, we've got our provider experience team. You can contact your provider engagement administrator or your provider relations coordinator. Next slide. And that was it for me. And I'm going to pass this back over to Chauncey. Thank you.
Thank you, Gaines. Next slide. I'm going to go over the upcoming provider meeting schedule. Our next scheduled meeting is October 8th, 2025 at 10. And then we will not have any meetings in November or December due to the holidays. Next slide. And I'm going to review a few resources, and then we'll start our question and answer section. One of the resources are where the provider forum information is from past provider forums. So if you go to the Trillium website under the For Providers section, you will see there you'll have the provider information heading, and under there you will select provider forum. And then you will be able to see the provider forum question and answer, provider forum presentation, and then provider forum recording there. All resources for you to be able to utilize. Next slide. And we want to thank you all for the participation, our subject matter experts, as well as all the providers that have attended. There's some resources here for you to be able to connect with us on social media as well as our contact information to reach out to our member recipient, provider service line, and our administrative and business number. And now we will begin with our question and answer. So first, we want to address the questions in the chat that have not been answered. I have been checking and I only see one that has not been answered. And it's more of a statement, but it says providers were told that we cannot add a member into HHA. Anyone on the call can take that question. Okay, we may have to, Ms. Barnes, I think I see Joyce Barnes. We may have to take that back and we'll add that information on the Q&A to get some clarification for you. I do not see any other questions that were not answered. Up, here's one. It would be wonderful to have the ability to click links when viewing the recorded sessions. Is there any way to drop the links down in the comments? Well, we are going to actually send the question, this PowerPoint actually out on the website as I just went over. So you'll be able to click the link during after the presentation, and then you'll have that resource there available to you. It's not really easy to do that during the presentation, during the recorded sessions. All right, and that was the last one that I saw that have been unanswered. Anyone who want to come off of mute, Jamie will raise your hand, use your raise your hand feature, and Jamie will take you off mute, and we will get your question.
So far, I don't see anyone, Chauncey. We could give it another minute.
Yeah, we'll give it another minute too. And as I stated before, the questions that are in the Q&A, we will bring that back on our resource page that I just instructed you to see, and we'll have those questions and answers there available for you as well. All right. If there are no hands raised, we want to appreciate you for attending our provider forum for September, and we will get this information posted on our website for you. Have a great day.